Hello everyone, and welcome to today's webinar, Community Health Center Investing in an Era of Delivery System and Payment Reform. I'm Dan Lowenstein. I'm Senior Director of Public Affairs for PCDC, the Primary Care Development Corporation, which works to expand access to quality primary care in underserved communities through capital investment, practice transformation services, and education and advocacy. And I will be moderating today's discussion. This webinar is in many ways a follow-up to a recent PCDC report released last year with the generous support and guidance from the RCHN Community Health Foundation called Community Health Center Growth and Sustainability, which includes 13 state profiles that we developed to help investors and other stakeholders better understand factors relevant to the operating environment of community health centers. Those of you who lead and support community health centers know that we are in an era of dynamic change. Healthcare delivery is moving from the institution to community settings, and healthcare reimbursement is moving from paying for individual services and encounters to paying for quality and outcomes. Comprehensive primary care, the kind that all community health centers are expected to deliver, and most do, is at the heart of this transformation. Now, community health centers are critically important to meeting the demand for quality primary and preventative health care brought on by the expansion of Medicaid and the affordable health insurance, while remaining the safety net for the millions across the country who remain without insurance. As a sector, they are well positioned for delivery system and payment reform. As of 2013, more than 60% were patient-centered medical homes, and nearly 90% were using electronic health records. They regularly report clinical, financial, and demographic data. Many are participating in accountable care organizations, value-based payment arrangements, and other initiatives designed to improve health outcomes and lower costs. But while we have some early indications that delivery system and payment reform will benefit and reward quality primary care providers, including community health centers, there are no guarantees. Historic underinvestment in primary care and a payment and delivery system structured on perverse incentives are tough problems to solve. Will there be adequate financial investment, partnerships, and policies to expand access to quality primary care for the 60 million Americans who do not have it? And how do health centers secure a central role in this future? Today we're going to try to address three questions. Which state and federal policies, as well as marketplace changes, are having the greatest impact on health center growth and sustainability, and to what end? How are community health centers preparing for and adapting to changes in the healthcare delivery and payment systems? And how should community investors assess opportunities to risk in this dynamic environment? We're going to hear the perspectives of four important perspectives today. Sherry Reinhardt, President and CEO of the Pennsylvania Association of Community Health Centers, which represents and supports 48 health center grantees operating in more than 200 sites and serving more than 700,000 patients each year. Eva Turbiner, President of Zufall Health, a federally qualified health center and patient-centered medical home that operates 9 sites in 6 New Jersey counties, serving over 26,000 patients each year, including public housing residents, migrant and seasonal farm workers, and homeless individuals. Peter Epp, co-managing director of Cohn-Resnick's healthcare insurance practice, a much sought-after resource in the sector. Peter and his team provide audit and tax consulting services. Health centers need to navigate change, streamline costs, and maintain the infrastructure and investment necessary for long-term success. And then Bill O'Brien, Chief Lending Officer for the Primary Care Development Corporation. Bill leads PCDC's lending activities, which last year alone totaled over $100 million of investment in community health centers, including deployment of $40 million in new market tax credits. After we hear from our speakers, we will be entertaining questions. And so to ask a question, you want to click on the little hand button to raise your hand that you see on the control panel. And when it's your turn, I will call your name and open your mic so you can ask a question. We'll take questions in order until the conclusion of the webinar. I would now like to turn it over to our first speaker, Sherry Reinhardt.
Thank you, Dan. I'd like to start by just making sure we're all on the same page. I'm going to use community health center, federally qualified health center, or FQHC interchangeably, and the elevator speech on what that is, using the FQHC as a mnemonic, is the FSC based on ability to pay. Everyone at 200% of poverty or below receives a sliding fee discount. Q is quality healthcare for all, because with the emphasis on the quality and the all, because every community health center has to contribute to the uniform data system, and their data is publicly available, and their doors are the only doors in the healthcare system other than the emergency department open to all. H, highly competent health professional team, and then C, what really distinguishes community health centers, and that's a consumer-driven board. Going to the first question, before I do that, I have to say that this year marks the 50th year of the first health centers in the nation, and probably some of the last 5-6 years have been some of the most challenging for health centers. A lot of money flowed their way with the American Recovery and Reinvestment Act and the ACA. There's been a lot of push for health centers to achieve patient-centered medical home recognition and make the changes necessary for that. A great deal of managed care expansion, an expectation that those health centers that were not doing outreach and enrollment would do so, greater coding expectations and complexity, Medicare PPS implementation, and just greater accountability overall. Some health centers have adapted to those pressures better than others. When we look at state and federal policies, I think with the Supreme Court decision about Medicaid expansion, the end result is state policy has become incredibly more important. With states, and multiple studies have shown that states that opted for Medicaid expansion, the health centers are doing better. In Pennsylvania, initially, even though we had a Republican legislature and governor, we were getting expansion, but through a private coverage option. With our new governor, we're going to a true Medicaid expansion, and we expect our health centers to benefit financially from that. We also have seen expansion of mandatory Medicaid managed care statewide. We've had managed care in Southeast Pennsylvania, Philadelphia region, and Pittsburgh for a long time, but now the entire state has mandatory Medicaid managed care. And what's really important in any state policy is, especially with managed care, is whether the health centers are in-network or out-of-network, whether the state is guaranteeing them their encounter or PPS rate, and how they're being paid. In Pennsylvania, a health center can have a medical, dental, and behavioral health visit in the same day and be paid for all three, which encourages integration of those services and for health centers to become one-stop shop, and not just for the individual, but for their family. So state policy has become even more critically important than it was in the past. The way our health centers are adapting are joining ACOs, really taking advantage of the outreach and enrollment dollars that they have received to try to get more people moved from the uninsured to the insured side of the equation. Looking at partnerships or building on partnerships that they've had. Some health centers have experienced significant growth as a result of the ACA and some of the changes in the healthcare environment. And those that have done the best at that are doing very well in the current healthcare environment. It's almost become those that have are getting, and those that have not are finding it even harder than they did before. We're seeing a new model, health center anchored healthcare homes, where health centers are building new buildings with enough capacity that they can put compatible services on site, like WIC, lab services, 340B pharmacy, and that is working very, very well. Patient-centered medical home is becoming increasingly important. In Pennsylvania, about half the health centers have that recognition, with a significant percentage beyond that pursuing it. Dan mentioned the 90% across the country with EHR. We're at 100% in Pennsylvania. And we're seeing a lot of, with managed care, a lot of opportunity for risk. Although we're not seeing upside and downside yet, I think that's going to take some more maturity and experience in the market for the health centers. Looking at how you, as investors, might assess opportunity and risk in the environment, first I would highly encourage you, again, look at the state environment, and your primary care association is probably the best place to get a summary of what's happening and whether it's an environment that's supportive of health centers. Looking at where there's growth and where there's unmet need. And I know the PCDC report is helpful in doing that. Payment policy changes, what's happened, what is in negotiation. Our primary care association was able to get all health centers in network and all health centers receiving PPS from managed care, which makes a difference with cash flow and the financial health of the health centers. How many health centers are being offered quality incentives, and how many with patient-centered medical home, because they will be really important. I think as we move forward, the biggest opportunity and challenge is going to be competition and complexity. There will be more insured, but there will be more competition for the insured, and there will also be more competition for the providers that we serve. Again, I think your best first stop, if you're trying to assess where there may be opportunity with a health center or with a state, is through the primary care association. And with that, I'll turn it back over to Dan.
Okay, thank you, Sherry. We're now going to hear from Eva. Eva Turburner, Zufall Health.
Okay, hi Dan, thank you very much. So today is an interesting day in New Jersey. Our governor has just declared himself a candidate for president, so that was big news. But probably the other big news more relevant to the FQHCs is there was the technical assistance webinar on the Expanded Services Initiative, and that is really emblematic of what's facing FQHCs as, from my perspective. We are under tremendous pressure to expand, serve more people, provide more services, do more comprehensive care. And yet, as with this expanded services funding, the availability of capital and the availability of strategic guidance is not necessarily associated with that.
She was messing with it before.
So we wanted to make sure that what we do here at Zufall, and I think my fellow FQHCs in New Jersey, would be to expand our services in an informed and strategic manner. So we face a lot of the same federal and state issues that Sherry was talking about, and I want to show here, I don't think I have control of my slides. Dan, can we make that happen?
Okay, working on that.
Or you can just move it down one.
Sure.
Yeah, there we go. So this is one of the outcomes of the Affordable Care Act. We are seeing among hospitals, and it's a very similar picture for FQHCs, that the need for and the provision of charity care has dropped like a rock. The single biggest factor has been the expansion of Medicaid eligibility. In New Jersey, the legislature and the governor made the decision to expand Medicaid right from the get-go, and it has been critical. Even Zufall, and we're pretty extreme in terms of the proportion of uninsured that we serve. We were just a couple of years ago at 70% uninsured. We are now down to 50%. So this has had a huge impact on us. We are seeing that other providers are, whoops, this went up a little too far. We are seeing that other providers are coming into the marketplace as more and more people have third-party coverage, particularly hospital-owned practices. And we, for the first time, have competition for adults who are very low income. And that has created a challenge for us. However, in New Jersey, of all the states in the U.S., New Jersey has the lowest proportion of private physicians who accept Medicaid, so there's still a tremendous lack of access, particularly among specialty care providers. In this second slide here on hospital admissions, inpatient admissions are way down. Now, this slide that the health department has put out is a little truncated, so the drop is not as extreme as it would appear from this, but it's down probably 8% and continues to drop. So the hospital industry is changing very rapidly here in New Jersey. A lot of consolidation of hospitals, a lot of acquisitions by for-profit hospital chains as well as not-for-profit. And there's been a huge increase in physician practice acquisition here in New Jersey. And a lot of changes in the hospital industry. On Friday, Morristown Medical Center here in our area of New Jersey just lost a court case where the town of Morristown went after them for property tax. And they said that even though Morristown was a not-for-profit hospital, that so many of its ventures were now in the for-profit mode that they should not be exempt from property taxes. And they lost that case, and I think it's going to have significant impact for the hospital industry here in New Jersey. The third factor that we're really looking at is the recognition of the role of primary care. And as this slide shows, 7 of the 10 most common causes of death are related to chronic illness. The entire system, including funders, including government, including the physician community, are understanding now that primary care is significant in curtailing costs and improving health outcomes. Dan mentioned changes in reimbursement models. We know that there is some value-based reimbursement that is coming in New Jersey. However, we haven't seen a lot of it. We know that we're getting some limited bonuses, but how those bonuses, particularly for Medicaid Advantage care, are going to intersect with the wraparound question is still an open book here in New Jersey. A lot of issues that we're facing there. We also are facing federal and state initiatives on population health. There is the ACOs for Medicaid and Medicare, CDC programs on community health. We are involved in behavioral health home pilots. And of course, New Jersey is a DSRIP state, and I know there's going to be some discussion about that afterwards. We are also looking at changes in technology and also in the pharma industry. Here in New Jersey, I think there's been pretty much universal adoption of EHR, but actual exchange with the hospitals and specialty practices has been very minimal. Here at ZUFO, we are certainly facing issues about medication accessibility. This becomes more and more important in the treatment of chronic disease, and certainly the issue of medication compliance is increasing dramatically as well. So, what is ZUFO doing? Let's see if, there we go. So how are we responding to all of those issues? And certainly, first and foremost, is capital improvements. ZUFO has always wanted to be the provider of choice. It is important to us to signal quality in our facilities, to have adequate facilities, and this has been a big challenge. We have been fortunate in getting a fair amount of the federal capital funding that's been offered over the last 5 years, and that's been very helpful, but it hasn't been sufficient. We have had to go out to different markets to get capital for expansion. We have accessed USDA financing, and let me just say, if anybody wants to talk to me about that later, I'll try and talk you out of it. It's extremely difficult. We have accessed mortgages on some of the buildings, bank loans, and we are fortunate enough to have a little bit of an endowment, and we have borrowed against the assets in our endowment also for capital expansion. we think it's critical as we have to compete more and more with hospital-owned practices that we know there's always been a stigma associated with going to the clinic, and we do our best to transform our image with that. Zufall has also been very much involved in workforce retraining and reorganization. We have a grant from the Robert Wood Johnson Foundation, which has allowed us to take a look at training and really reorganization of patient staff duties. So we have increased very much our support staffing, particularly around care management. The whole PCMH movement has really had a significant impact on our use of space and on our need for technology. Our largest single building we redid with FIP funding just 3 years ago. We've already outgrown it because of the care management function. So many more people are needed in clinical areas. They need computers, they need phones, they need the ability to contact patients outside of when they are actually in our facility. We are also looking at hiring and using different types of providers who are now billable. So Zufall, for example, is using clinical pharmacists. We have more nutrition services available, certified diabetes educators, and we are looking at how those providers can be used to bring in revenue as well as to help with clinical outcomes. I think that all of the FQHCs and Zufall is working on this very strongly. It's working on increasing our programs for seniors. We have a full-time senior care manager, and we are involved very heavily in doing those annual wellness visits. We are a part of the Atlantic Care ACO, so we are really working hard on seniors programs because there is significant reimbursement as well as value-based reimbursement. We've also been looking at incentives, and these are both internal and external. We are trying to negotiate as best we can with the managed care companies for value-based reimbursement. We are also focusing on compensating our providers based on a variety of indicators, not the least of which is productivity. Hospital relations are tough here in New Jersey. I'm not aware of very many successful partnerships among the New Jersey FQHCs and their local hospitals. The hospitals are, as I say, in expansion mode, acquisition mode, hiring primary care providers in competition with us, and I think it's been tough in New Jersey with the hospitals. So there may be other states where this has gone better, but I don't see it here. Zufall has really stepped up in terms of using technology, particularly for data analysis. We went out and hired a full-time data analyst for our staff who is providing reports for all of our management functions as well as our clinical outcomes. We couldn't really operate at the level we do without that data analyst on our staff. And finally, federal and state transformation initiatives, we've tried to participate as much as we can. In particular, I do want to mention DSRIP. New Jersey, as is New York and a few other states, has this delivery system reform, and it is taking money in New Jersey that previously went to the hospitals as charity care and giving it to them now that they have to work for it in terms of having clinical outcomes. The problem with DSRIP here in New Jersey is that although all the incentives go to the hospitals, the outcomes that the state is looking for are really based on primary care related conditions. And so all of us in the FQHC world are now being asked to share our clinical outcomes data with our local hospitals, even though there's no funding to support that activity. And that's really been a big issue for us. So I think that that is probably it for me, and I'll be happy to take questions at the end.
Okay. Thank you very much, Eva. Now we're going to hear from our third speaker, Peter Epp.
Hello, everybody. So as Dan mentioned, my name is Peter Epp. I'm a partner here at Cohn-Resnick, and I'm going to sort of bring a national flair to this discussion. I think what you've heard from Sherry and Eva is pretty much similar to what you're going to hear from me. But when you look at what's going on nationally and some of the recent changes, it's really all about what I often call the tangled web of health center financing. Because of the populations that the health centers serve, we receive grants and contracts to serve the uninsured or for special projects, as well as we have revenues coming in from third-party payers. And both of them are under attack as we sit here today. From a payment reform perspective, or how the payers are looking at paying, the two general themes you're starting to see out there is a move away from being paid on a per visit basis. As you've heard earlier, moving from volume to value is sort of the the marching orders today, and the way states and even the federal government is looking at this is really two things. One, moving more and more of the patients into managed care organizations or managed care benefits, where a managed care plan or health plan is really managing the care of those patients, and you're starting to see a move away from being paid on a per visit basis to being paid on a per patient basis. So regardless of the number of services a patient receives or how many times they come in, the health centers would receive sort of a flat fixed payment per month for that patient. So the thrust here is you're starting to see movement away from volume to really patient-centered. And there's different models as to how they come up with those numbers. The second thing is pay for performance, which Eva was speaking about, that plans are now starting to make additional payments for improved health outcomes or for best practices like immunizations for children. So you're starting to see the payment mechanisms change to sort of drive behaviors. So that's on the managed care side. The other thing that we're often hearing about is value-based payment, and this is the national cry, the triple aim, which is about value equals reduced cost but improved health outcomes. And so there's a number of things going on around this. Medicare this past January announced its goals, where they plan to move the fee-for-service program to some form of alternative payment models, which are ACOs or bundled payments, to move 30% of the fee-for-service system into alternative payments by 2016 and 50% by 2018, and also starting to move or tie fee-for-service payments to quality and value. And the goal there is by 2018, 90%. So Medicare has stated those goals. Usually, as we say in the finance side, where Medicare goes, the rest of the payers follow. Eva had also mentioned about Medicaid. There are 6 states at this point that have implemented Medicaid waivers that are called delivery system reform incentive payment programs, where the states have asked for money to redesign the system. Often how they're set up is the dollars come out to pay for infrastructure development, then moving on to system redesign, then on to clinical outcomes and population health. So New Jersey has one. New York, which was the last one to go in, has a very rigorous and extensive program, which is where I'm from, where they're actually forcing networks, so forcing hospitals, home care agencies, nursing homes, and so forth to kind of work together and get into risk-based payment. So it's forcing marriages, which is creating a little bit of hysteria here in our state. So you have the payment system really changing, and what's happening on top of it is the new competition for our patients, and especially the Medicaid patients. Physician practices in hospitals have historically stayed out of the Medicaid line of business, mainly because the payments under the fee-for-service model were very low. But as we move to value-based payment, which is where they've been playing now for years, Medicaid is now a lucrative payer. And so you're now starting to see renewed interest in the Medicaid patients. Plus, as Eva had mentioned, the value-based payment is very much, the foundation is around the primary care delivery system and primary care providers. So hospitals are really starting on the move to open and expand their primary care delivery system. So there's a lot of competition out there now for our patients. Insurance coverage expansion, we all know about that. The types of patients that are now being seen at the health centers are starting to change. More Medicaid, less uninsured, which from a bottom line perspective is often a good thing for the health centers, but we also have these new qualified health plans with these high deductible plans, which are creating other types of headaches for the health centers. So, the mix of patients is changing, and it's something that the centers are monitoring. Funding for the uninsured, as more and more folks move out of the uninsured bucket and into other types of insurance, the dollars that exist out there are starting to be reduced. We had a big fight, nationally. We had what was called the fiscal cliff to reauthorize the 330 Community Health Center Grant Program. We got it reauthorized for a couple of years, but that fight will be renewed in a few years from now, and I'm sure it will be a little bit more difficult. And in some states, the uncompensated care programs are not now coming under review, especially if CMS or the federal government is providing matching funds to them. So you have, a change in the patient, the revenues paid by third-party payers, and plus this downward pressure on the grants and subsidies we receive for the uninsured. And lastly is our FQHC Medicaid program. It has been under attack nationally for some time now. And, one of the questions, that is posed is, well, what happens to the program as more and more folks move into managed care and we move into value-based payment? Here in New York, this is a big discussion. Some states like Oregon and California have implemented alternative payment methodologies where they're starting to look at paying for this no longer on a per visit basis, but on a per patient basis. So again, you can see the theme is about moving payment towards patient-centered payments, and also looking at outcomes. Okay, there we go. As far as responses, I guess I've bucketed them into what you see there up on the slide. Again, moving into improving value. So we're focusing on health outcomes and performance to access additional dollars. And then there's this idea of managing the total cost of care of patients. And this is the big change for the primary care providers and the health centers out in the world, where now they have to manage the claims and the services provided not only within their four walls but outside. Often these value-based payment programs retain some level of the fee-for-service system, so there continues to be some payment for services delivered, but then there's the carrot is really in the management of the total cost of care. What you're starting to see is the evolution of care management. Health centers have been doing, care management, since the beginning. We're all, very much ahead of the curve as far as patient-centered medical homes are concerned. But now as this becomes critical to managing the total cost of care, all of a sudden hospitals and other organizations are starting to pop up to provide care management services. So there's the centers should be in a strong position here, but really need to, to stand their ground to make sure they're involved in that process. Provider of choice is now the big buzzword out there because of the competition. So our patients, we need lots of happy patients is my phrase. We want to make sure that as the choices increases that they continue to come back to the health center, so patient satisfaction is very important. From an internal perspective and looking at the service delivery within our four walls, as our other payment models start to become more threatened, we need to really start to look at reducing our cost per unit there, cost per visit. And you're starting to see now a shift because the payment models are going towards paying on a per patient basis, changing the way we provide services to managing a panel. So how many patients a physician and a care manager and so forth a team can handle, and moving towards a team-based care perspective. The other thing you're now starting to see is formation of collaborative networks and IPAs as we start to talk about taking on risk. To survive in that world, it's numbers, and also collaborative networks allow for the sharing of best practices and maybe the sharing of costs. So you're starting to see networking and large provider systems kind of coming together New skill sets are required, and now saying CMOs and CFOs are now going to be BFFs, best friends, because you'll see a lot of the revenue is now going to be driven by clinical decisions and what occurs in the exam room. Skills are data analytics, as Eva had mentioned, and also clinical informatics. Somebody who's able to, with a clinical background, is able to look at data and be able to implement interventions to drive change. And then technology is all over the place. Managing claims data, business intelligence are going to be critical to the future. So that's sort of where I see the health centers from a national perspective. Dan?
Okay, I had myself on mute. Thanks very much, Peter. We're now going to hear from our final speaker, Bill O'Brien.
Hi, thanks, Dan. Let me just make sure I can do this. Great. So my comments will be from a lender's perspective or a provider of capital into an industry whose revenue model is changing. And so where we are positioning ourselves is to both provide capital to organizations that need it now, but knowing that their sources of revenue and the way they conduct their business is going to be undergoing a significant change very often during the life of that loan. And that is a very, very unique position to be in. Most lenders would shy away from something like that. But CDFIs as a whole, that is part of our mission. So in order to accommodate that, we have to get our hands around, well, what are some of the proxies, so to speak, from traditional analyses? Before I get into that, just to give you a sense of who PCDC is and why we think we have an opinion about it, we were founded in 1993 with a singular mission, and that is to expand and transform primary care in underserved communities. Dan very briefly mentioned the three programs we have: capital investment, which is the team that I'm a part of; performance improvement, which is focused on the transformation of primary care; and then policy and advocacy, which Dan runs, which is the promotion of primary care. Capital investment being, of course, the expansion of primary care. Our impact as an organization, I think, has been substantive. Since we were founded, we've invested, we've arranged well over $650 million in over 100 projects, positively impacting the lives of 900,000 patients. We've improved over 850,000 square feet and strengthened over 900 healthcare organizations, and we estimate that we've created or retained more than 6,500 jobs. Some of the financings that we've done have both been short-term and long-term. The short-term financings can be anything from pre-development of a construction loan, smaller scale projects, bridge loans to reimbursement grants, etc. On the long-term financing side, we'll do recapitalizations, leasehold improvements, permanent financing, what we would call permanent financing, which is effectively to term out a construction project, renovations, expansions, acquisitions, and then new markets tax credits. And featured on that slide is a project that we completed this year for both debt and through new markets financing in Monroe, Louisiana, which is in the northeast part of that state, Primary Health Services Center. Next slide. So, given that what we've done over this time, and obviously the vast majority of our history has been on a more traditional credit evaluation, but we know now that that is changing, and some of the tenets that we used to evaluate these projects are undergoing significant change. Nevertheless, this year alone, we've done we've arranged well over 120 million of capital for projects. So how are we doing that, and what are some of the things that we're doing to supplement our more traditional evaluation? That traditional evaluation would typically look at a qualitative aspect of the project, which is primarily the need associated in the community. That is both from a mission viewpoint, so we're trying to expand primary care in the community, but also from a risk management viewpoint. Are the people going to use this facility? And what is the capacity of the center to both manage its operations as in a norm, manage the operations during the implementation of the project, and then what is the capacity of the center to manage the project as a whole? Typically, health centers do a great job of delivering health care, but you would not normally expect that they would have the internal capacity to manage large-scale projects. They may do it once, maybe twice in a CEO's lifetime or a career in that center. So you would expect them to at least be cognizant that they need external help. Then we do what you would expect any financial lender to do, financial projections. And historically, that has been cash flow projections and sensitivity analysis, all built around a given. And the given is the ability to measure what revenues will be. And if historically, a health center has been increasing, say, 3 to 5 to 10% per annum, and they manage their costs, well, then it's not overly complicated to figure out what can we expect their cash flows to be. The problem is that that's going to change, and as Eva had mentioned, while many states are implementing this from some degree or another, very few have actually come forward with this is what the model will be. So how do you go about estimating your ability to or manage your risk on projects and health centers, not knowing exactly what that model is going to be? Well, we view this as what I would call a top-down, bottom-up approach. And the top-down would be looking at what federal and state policies are and what changes are and estimating their implementation of timing. Certainly at the federal level, we look at challenges and threats to the ACA and how they've fallen out. Certainly we've been doing projects over the past couple of years, and those challenges and resolutions have been legion, it seems. We look at changes to Medicaid, and we look at changes to Medicare. As Peter mentioned, some of the changes to Medicare are a precursor to what we might expect on Medicaid. We look to Dan and his team for policy changes. We look to NAC, and we look elsewhere to other third parties to gather as much information as we can to make educated decisions on that. On the state level, we certainly look at how supportive are states of FQHCs and community health care in general, in primary care. The number one thing is, as Sherry mentioned, as a policy, we speak with any state that we do business in, we speak with the PCA to get their view on both the status of their constituents, but more importantly, what they view the future to be in terms of policy and implementation by the state. It is not uncommon for us to read a state budget. We will pull up the state budget and read the language to see exactly what do the states, what are their opinions about primary care. Are they supportive or aren't they? And by the way, as Sherry mentioned about using things interchangeably, it is typical for a primary care center to provide more than primary care. Well, on a state level, how supportive is the state towards their dental program? How supportive is it towards behavioral health? If you're providing financing for a center that's going to be providing integrated care, you need to know what the state's policy is and their supports of these. The one comment I would also add there is the state may not be. So not every project that we look at are the state's support of those initiatives glowing, not by a long shot. But what we do need to know is how are the centers managing that? And for that we turn and that's when you begin to look directly at the community health center itself, both its current performance and its preparations for the future. Now at the moment, we have nothing else to go by other than our traditional cash flow lending model, and so we continue to use that to get a sense of, not that we necessarily think over the next 5, 6, 7, 10 years that nothing's going to change, but what are their margins like? What are their cash flow margins, their operating margins? Can they withstand downturns that you would reasonably expect a changeover in revenue of a revenue model to bring? The data capacity, whether or not, I mean, for the most part, as Dan had mentioned, something like 90% of FQHCs now have EHR platforms. But there is a difference between having the platform, using it, and even using it well. And so what we want to see is that the FQHCs have the ability to implement and work on their EHR platforms and be able to manipulate data to demonstrate those quality measurements. So having some level of EHR implementation, say meaningful use recognition, for us is critical. If the center doesn't have it yet, we would certainly expect them to get it. We would certainly want management to say they want it. Now, it does raise an interesting point. When you look at the spectrum of FQHCs, you run the gamut from literally one site, small community centers, up to the multiple sites that would, in the commercial world, not qualify as a small business anymore. How do those centers and FQHCs even out in terms of their EHR platforms? For there, we do want to see how those centers compensate for perhaps lack of capital and lack of resources to use EHR. We would want the medical home as an important aspect, both for the delivery of quality and the opportunity to receive incentive payments. We are very bullish on seeing the centers begin to look at alternative payment methods. Eva mentioned before that Zufall is doing that. We're seeing that on an ad hoc basis across the country. But at the very least, it demonstrates management's recognition of what's to come and their ability to get out in front of that curve. And then finally, we would like to see some degree of ACO or networking among the health center and its peer group in the community, be that hospitals, etc. We see that being fostered on a case-by-case basis by PCAs. Sometimes the PCAs take the lead in coordinating that. Other times it's the community health centers themselves. I think that's it for me, Dan.
Okay, thank you very much, Bill. We're now going to go to questions. To ask a question, please click on the raise hand button in your control panel here. And when your name is called, I'll open up your line and you can call your name and you can ask a question. All right. I'm going to start off with one for our panelists. There's a lot of initiatives happening, a lot of change, and health centers are both being asked to take on a lot and are taking on a lot. this is all for a future that we sort of see, but it's still somewhat uncertain. And so we're using proxies, we're using leading indicators in many cases. Can you say, if you looked at a health center or a group of health centers, what would you consider the best leading indicator of success in an environment that consists of a value-based payment and delivery system reform?
This is Sherry. I would say their leadership. And I say that because we have, as Bill mentioned, there are small single-site health centers. We have our largest health center has over 40 sites, and we have some very strong small health centers because they are very strong leaders.
Yeah, this is Peter. I would echo Sherry's comments. One of the things I see as I go around the country is, and I use this phrase a lot, there's some centers, many centers are what I call stuck in the mud. There's so much going on that they just don't know which way to go. But it's really about leadership, really kind of embracing the change and getting involved in things early on so that they're positioning themselves, for the future success.
This is Eva. I would also add in, still along the lines of leadership, is we found it very important to stay involved and understand at the federal and state levels what's going on. So showing up at the conferences, understanding, attending things like this webinar even have been very important to us in keeping us at the forefront, or what we call the bleeding edge of innovation.
Yeah, not to just join into the same zone here, but I would agree. But conversely, we have we speak with many health centers, and there have been the minority of health centers that will actually come back and say, we're not worried about it. We'll worry about it when the time comes. That's endemic. That's a problem waiting to happen.
I'm going to ask another question. Again, folks who feel free to join in. Don't be shy. Just raise your hand there, and we'll get your question in. There's about 5 minutes left. Both Peter and I think you all mentioned the new entrants into primary care, hospitals in particular that are sort of seeing the writing on the wall and getting into this sector. You also have retail clinics and urgent care clinics. Do you see are these primarily threats, or are there partnership opportunities with them, given their maybe the role of a community health center as a comprehensive primary care provider, and some of the more limited roles of others who do provide primary care?
This is Eva. Let me speak to that for a minute. We have found it very difficult to foster collaboration around the provision of primary care services, and to some extent specialty. The local hospitals will do what they're going to do. We recently had a hospital put a primary care site about a half a mile from our largest site here in Dover. And I can't be sad about it. They're accepting the Medicaid plans. They're even taking charity care. The real issue comes in as to when that new primary care practice is all full up with insured patients, whether they will start to dump the Medicaid and the uninsured, and we'll be back to where we used to be. So what I would have preferred to see from the hospital is for them to have put accessible specialty care physicians in that site just down the road. We've had a very hard time collaborating with our hospitals, and I'm not optimistic about it in general.
This is Sherry. In Pennsylvania, we have 3 times now offered with the Primary Care Association in collaboration with the Hospital Association a day-and-a-half program on hospital health center successful models of collaboration, which seems to have helped. I mean, we have pockets where it's still challenging, but I think coming from the hospital world with 17 years as Vice President of the Hospital Association of Pennsylvania, a lot of the challenges we've seen are the hospitals don't understand health centers and don't understand that they can't control, and they think it's just an individual decision. And the more they understand what the requirements are, the more willing they are to relook at partnership and how that might be structured.
Yeah, and I think I'd probably say, this is Peter, I think there's different models in different geographies. I think there are some very collaborative situations with a hospital and a health center. However, those are usually pretty long-standing, built over long periods of time, where there are collaborative efforts with the primary care expansion, and backup from the hospital. But I think that's probably the minority, and most are sort of a struggle that Eva sort of alluded to. So I think there's a difference, but it's important to understand how they, how they shake out individually.
Yeah, I would also. Sorry, Sherry, go ahead.
I was just going to say, in response to what you said, Peter, that we've seen the partnerships or the long-standing relationships and the new. The brand new health centers where there's not a history and sometimes a negative history that gets in the way. That's where we have our most robust partnerships.
Yeah, as we've gone around the country, we know of and have actually been helped finance some of those collaborations. And I'm thinking of Colorado, and to a lesser extent, Connecticut and Louisiana. But I would say there were two critical components to it. One is certainly on a lesser degree of integration. It's more of collaboration, and that is the FQHCs getting out in front of it and approaching the hospitals with providing a service to the hospital, such as a residency training program. That doesn't always work, and it really has to. That's a case-by-case basis. In other cases, and I'm thinking, Pennsylvania, I think, is a great example. The PCA helps there, with Sherry and her team. PCA helps there. That's true for Colorado as well, to try to make this a more successful integration between the center and the hospital.
Okay. We are at 2 o'clock. We do have a few questions in here. Let's see if they're still here. They may not be. No, I think they've hung up. Okay, we're at our close now. I want to just thank our panelists and thank our participants for joining on this webinar. We will be sending a recording to all who registered, and it will also be available on our website. And we'll also be sending our panelists' contact information to you. If you have questions about lending, please contact Bill O'Brien. His information is here and will be sent to you as well. Again, thank you very much for attending this webinar, and have a nice day.